Great. Continued documentation about the limitations of retrospective mortality surveys have put a lot of focus on using prospective surveillance to collect vital events data. This is what we're looking at. While most developed countries have reliable national-level vital events registration systems, in developing countries, the systems are far less reliable if they exist at all. But it's exactly in these type of settings, in these low-resource, poverty-stricken settings, where mortality data is most critical. And having valid evidence would really would be the most beneficial to healthcare decision makers. Some rural regions of Africa, 80% of all childhood deaths happen at home. And these deaths are not reported to any routine collection system. So now you have the deaths not being reported, and you also don't know what caused the deaths. Reporting for births is considerably higher, but even those numbers are far less than UN estimations. Currently, how this problem is being dealt with for mortality rates is through retrospective surveys. Surveys are normally done 6 months or a year after an event, so by the time you get the data in, the time to act on that data has already passed. You're making decisions based on data that has questionable validity, and it's a year old, it's 18 months old. Another challenge that we were working with is that we wanted projects to be scalable. The vital events systems and the locations where IRC is working, we need these projects to integrate into the Ministry of Health guidelines and to be adaptable from the Ministry of Health. So now if we're talking sub-Saharan Africa, needing to scale up with the Ministry of Health, it brings up a lot of ideas of costs and logistics and what can be accomplished. Two different projects. Okay. Focus on two different projects. One in Kenema, Sierra Leone, the other in Congo, in the Ruanguba Health Zone, which is in North Kivu. We were looking at the feasibility of setting up vital events registration systems using community health workers. In each case, one of the challenges we ran into was low literate community health workers. In DRC, there's some level of literacy, but in Sierra Leone, it is very low literate. There was no requirement for literacy to be included in the community health worker system, and this is by Ministry of Health guidelines. Projects were set up a little differently. In Sierra Leone, we had one community health worker for 30 to 50 households, and in Congo, it was one community health worker for 15 households. The Congo program was set up to also determine rates. It was set up as a representative sample for an entire health zone. Job descriptions of each community health worker is somewhat different. In Sierra Leone, basic child treatment. In Congo, they do mostly health promotion and referral to facilities. And you also see the size of the projects we were covering. In Sierra Leone, we were working with 60 community health workers, and in Congo, it was 40 community health workers. These were our methods. It started with enhanced training. The biggest challenge with the enhanced training right away was mortality identification. Understanding exactly the definitions for births, for deaths, questions about stillborns and about maternal mortality. very difficult in some settings to narrow down. We were looking at how our training was going to integrate into the existing community health worker training. We couldn't have a parallel reporting system. We didn't want to affect the Ministry of Health training to a point where it couldn't be integrated. The next challenge was the phones. In both projects, community health workers would be sending weekly reports of vital events and migration data into an online system. A lot of differences here. In Sierra Leone, when we approached them with the project, when we approached the community health workers, normally they had phones already. They thought we should have been doing this a long time ago. We were way behind the times, and this was really hard to hear from a community health worker in the middle of Africa. In DRC, however, it was a completely different story. It was the first time this level of technology was being introduced to this setting, and made it a lot more challenging. The training had to be increased considerably, talking about how to turn a phone on, and just going through the idea of what the phones can do. This is a picture from Congo. This is the first time this community health worker has ever seen a mobile phone. Along with the training, we also needed to create job aids. The job aids would bring the community health workers directly through the reporting process, what we were looking for, how the reports were to be sent, and how the phones were to be used. This is an example of one of the job aids in Sierra Leone. Very basic data using very basic phones. There were options to use more advanced phones, Java-enabled smartphones, but when you're talking about scalability, especially in developing countries, it's just not a realistic possibility. But $10 or $15 basic phones is a possibility. Reporting. Reporting, we had two ideas. There were basic paper reporting in notebooks with vital event and migration data. The data was also sent via mobile phone to EpiSurveyor, which developed a SMS reporting application for this project. Analysis, once it was online, could be done at the health facility, at the village level, at the country level, and at the national level. As the data was aggregated onto an online database, it became possible to see the data in real time. Supervision was also enhanced. Supervisors looked at the types of data that was coming in, whether the data matched from the phones to the notebooks, and followed up on any questions. Results. When you're working in unstable environments, one of our biggest problems was displacement. In April, due to a rebel uprising in Congo, our entire area and all of our community health workers fled into Uganda, into camps. It was something unexpected, and it was interesting to see how the system continued throughout that period. Reporting percentage, we had very high reporting percentages in both projects, 96% in Sierra Leone and 100% in Congo over a 12-month period. And data accuracy, in Sierra Leone, the data was checked, and the vital events, births and deaths, had about a 92% data capture rate. Lessons learned. Okay, literacy, power, and coverage, they were all solutions. Low literacy doesn't mean low numeracy. We had community health workers who had trouble writing down paper reports during the exercises, but when they were given a phone, were able to text in the numbers, which was a big advancement from what we thought we'd see. For power sources for the phones, Community health workers came up with solutions using credit to power their phones. We tried solar chargers. There was a lot of difficulty with solar chargers in these environments. And the mobile coverage, even though it was low mobile coverage areas, community health workers, because they were familiar with the village, knew places they could go where there was some amount of coverage. Sometimes there were examples of community health workers holding a mobile phone up against a tree, and they would know that they could get coverage that way. There was a cost advantage. The entire project and the continued data collection is a lot cheaper than retrospective mortality surveys that need a lot of technical support, need a lot of logistics, and usually have to cover a much bigger area. Supervision was essential. Supervision in terms of data quality and following up for any phone problems and reporting issues. And displacement adaptable. This has been the most interesting thing I think that's come out of this. In Congo, in Sierra Leone, very little displacement. We had about 6% migration rate, but in Congo, where at some points there was a 90 or 100% displacement, using a mobile phone, population and surveillance data was able to be continued even though the people were not in their designated areas. If we had a paper system, this wouldn't have been the case. The data flow would have been completely disrupted. And this is just a quick list of the research partners we were working with. And I think I went a little bit over time, but I think there's time for one question. Or two questions? Yes? Yeah. We looked at that during sample selection. We looked at the different types of areas and the coverage. And we did a random sample of villages. Some of them had mobile coverage, some of them didn't have mobile coverage. And we saw examples like that in areas where there was listed that there was no mobile coverage, and the provider, the cell phone service provider, didn't think there was coverage either. But the villages or people in the village knew places where they could get enough service to send a text message. Yes? Sorry.
You mentioned that you were able to verify that 90% of the vital events were like they were actually happened. How did you verify that?
We did a census and recensus method. There was a baseline census done at the beginning of a project, of the beginning of each project, where we knew household members, GPS locations, and went through a line listing to get a demographic profile. In that area, then, we followed the vital events that were being reported via the mobile phone, and then recensused at the end of 12 months. And then we also analyzed that data against what the ministry was reporting in the area and against other surveys. But it was basically a census recensus. Right. Thank you very much.
Hi, good afternoon. My name is Marcos. I'm from Puerto Rico, Ponce School of Medicine. So this presentation has three main objectives. First, I want to provide a brief overview of mobile technology in social science. Second, I will present how we have been using the iPad to document behavioral manifestation of HIV stigma in medical student and patient interactions. This will give us an idea of the potential of mobile technology to explore social issues in health scenarios. And also, I'm going to discuss limitation and future research using mobile technology in social science. First, I want to highlight the impact of mobile technology to explore and understand new ways to address social issues that have implications on people's health. For example, we have seen that mobile technology has played a crucial role in addressing social determinants of health, such as geographical location and health education literacy. This is possible in part for the new capability and tools that mobile technology adds to scientists. We begin to see more technology, more effective ways to collect, store, and analyze quantitative and qualitative data. Also, more tools to collect ethnographic data such as pictures, videos, audio recording in different places at the same time. All this has allowed a better understanding of social issues related to health. All this means that mobile technology in some part for social and behavioral scientists has many implications in how we approach and understand social issues in health scenarios. We in Puerto Rico, in an effort to document and better understand the role of social science and mobile technology in health scenario, I will present and discuss our preliminary result documenting behavioral manifestation of HIV stigma. Let's talk about HIV stigma and health. Stigma toward people with HIV has been identified as one of the central barriers to effective prevention and care. Knowing these implications, new intervention of prevention and care toward HIV points out the need to reduce HIV stigma among health scenarios. Researchers have documented how quality of health services decrease when HIV stigma is present among health providers. For this reason, the development of instruments and techniques to measure attitudinal and behavioral stigma manifestation among health professionals has been crucial. Now I will present how we document behavioral stigma manifestation introducing the iPad to collect, store, and analyze quantitative and qualitative data. Using a sequential mixed method design, we developed 3 phases. In this graphic, we can see the 3 phases. The first phase consists of 9 focus groups with 66 persons with HIV. This phase allowed the development of an instrument to measure behavioral manifestation of HIV stigma. In the second phase consists of 91 medical student and patient interaction using the standardized patient program of the University of Puerto Rico. This standardized patient program is a controlled scenario where medical students are video recorded during a clinical intervention for evaluation purpose. For this study, we developed 3 different cases of patients with HIV. Before the simulation, the medical student complete a demographic data questionnaire and a scale to measure attitudinal manifestation of HIV stigma. After the simulation recorded in video, the patient and 3 external evaluators complete the scale developed during the first phase to measure behavioral manifestation of HIV stigma. In the third phase, we integrate all the quantitative and qualitative data. Now, I will show how we integrate the iPad in the different phase. In the first phase, that was the qualitative phase, we use iAnnotate, which is an iPad application to analyze the qualitative data from the 9 focus group. This iAnnotate is an iPad application created to read, mark, and share documents. This allowed the researchers to code and triangulate all the qualitative data and develop the HIV stigma behavioral manifestation scale. In the second phase, we use iSurvey app. We built all the instruments in this application. These instruments were the behavioral manifestation scale, the scale to measure attitudinal HIV stigma manifestation, a social disability scale, and the demographic questionnaire. Also, this allows us to document and store in a cloud all the quantitative data before and after the simulated interactions. In the third phase, we use the cloud storage and we extracted to SPSS and analyze all the documents. Here in this picture, we can see the environment where the student and the patient all well video recorded. I'm going to show now our preliminary results. We already have identified some attitudinal stigma manifestation. For example, 39% of the participants strongly agree that a person with HIV should always be required to disclose their status to health professionals so that they can take the proper precaution. A 37% strongly agree that should be a law to force people with HIV to disclose their status to their sexual partner. Also, 43% were not surprised if a promiscuous person were infected with HIV. Now we identify behavioral stigma manifestations such as speak up to the patient, not distinguish between HIV and AIDS during clinical care, avoid shaking hands to the patient, and talk about HIV as a terminal condition rather than a chronic condition. In the first place, the iPad allows us to document HIV stigma manifestation in a busy and complex health scenario. We saw a fluid collection of data. This means a significant reduction of participation time, which is crucial in busy environment. Also, considering the portability of the iPad, it adapts ease to the environment. In relation to storage of data, the application use allows the collection without need internet connection. Moreover, the effective management of this data allows a better organization and reduction of research data entry error. However, we identify new forms to do research and understand social phenomena, and new limitations and questions rise. One of our principal limitations was the need of more strong application developed for social science, and specifically the measure of HIV stigma among health professionals. Furthermore, the use of this technology raises new questions and areas of study related to psychosocial implications. For example, what are the cognitive implications of mobile technology data collection on HIV stigma manifestation? Also, there is a need to develop new research using mobile technology to measure HIV stigma among highly stigmatized population in health scenarios, for example, drug users and sex workers. Thank you.
We'll take 2 questions. We'll take 2 questions, but please use the floor mics.
Thank you for coming today. I'm going to tell you a little bit about a study that we did using text messaging to assess fever rates after influenza and pneumococcal vaccination in the 2011-12 influenza season. So there are 3 common ways that we conduct vaccine adverse event surveillance in the U.S. The first is reporting by providers and others to a system like VAERS, which is more passive reporting. We also have large linked database studies, which are often retrospective and rely on medically attended events and ICD-9 codes, and so can't capture events that people aren't coming into the doctor for. And the third are prospective clinical cohort studies, but those are often very personnel intensive or time intensive. And so we were interested in seeing if we could use text messaging to help augment these vaccine surveillance methods. So why text messaging? Although obviously here everyone believes in text messaging. But almost everyone has cell phones, both in the US and internationally. And there's more and more research that's being done on the use of text messaging. And we had previously used text messaging to increase influenza and other vaccine coverage, and had conducted a pilot study which had shown that potentially we could use text messaging for vaccine adverse surveillance. But there was no published studies that used text messaging for a prospective hypothesis-driven vaccine safety research. So we focused on fever rates with influenza vaccination because in the 2010-11 season, there was an increase in febrile seizures that were noted, particularly in children who were 6 to 59 months old. And the highest risks were in the younger kids, 6 to 23 months old, who had been given influenza vaccine, the injectable form, and pneumococcal vaccination at the same time. And there were a couple of remaining questions. First was to corroborate those findings. That was done in a single season and was a self-controlled analysis study. So basically children weren't directly compared to each other who got different types of vaccination. In addition, we wanted to assess what was the risk window for fever itself, because if we could show that that risk was also in a day 0 to 1 period, and that would strengthen the biological plausibility of the febrile seizures being caused by giving pneumococcal and flu vaccine at the same time. And then we also wanted to know about the risk of fever itself, because fever can lead to medical visits, it can be upsetting for parents, and there are certain groups of children who you would want to avoid having an increased fever risk for. So the goal of our study was to assess the risk of fever in children 6 to 23 months old who were receiving simultaneous administration of influenza vaccine and pneumococcal Prevnar, which is PCV13 vaccine, compared to those who were receiving either separately. And our hypothesis was that those who were receiving it together would have higher fever rates in the day 0 to 1 period than receiving either one separately. And that we would see that in day 0 to 1, but we would not see that in day 2 through 7. We also wanted to assess the utility and acceptability of using text messaging for this kind of vaccine adverse event surveillance. We hypothesized that parents would be willing to report use text messaging to report both presence but also absence of fever, and that they would be satisfied with the use of text messaging. So to be eligible in the study, the parents had to have a child who was 6 to 23 months old, who were visiting one of our study sites, which I'll talk about. They had to be receiving either vaccine together or separately, and they could receive other vaccines at the same time. They also had to have a cell phone with text messaging, and they had to speak English or Spanish, which is the vast majority of our population. This was an observational prospective cohort study, which means that children who were receiving vaccination based on what their healthcare provider was giving them, we weren't having any influence on what vaccine they were being given. And families were recruited from the Columbia University Medical Center, New York Presbyterian Hospital sites at the time of vaccination. They signed a consent form, did an intake form, and then we trained them in the use of a temporal artery thermometer, and then they enrolled via text messaging using their own cell phone. Then starting that night, which is day 0, which is the day of vaccination, they were sent a text message at 8 o'clock that night, and then sent another message on day 1 through 7 at 8 p.m. each of the next nights. And the series of messages basically collected from them what was first the category of temperature, which I'll show you in a second, what was the actual temperature, what time it was taken, if they took any kind of antipyretic medication, and if so, what time, and any care that was sought. So this is the first message, which basically was trying to get at what was the highest temperature in a category they had had in the last 24-hour period. For our case definitions, day 0 was from the time of vaccination up until the response to that first text message that night at 8 p.m., and then days 1 through 7 followed. For fever, we looked at first any, which was greater than or equal to 100.4, and then also moderate fever, which was greater than or equal to 102.2. And we used chi-square comparisons as well as log binomial regressions to adjust for factors that may confound the relationship, and I'll talk about those in a second. So nearly everyone who we approached was eligible, that's 82%, and nearly all of them, 86%, enrolled. And because families could enroll more than once if they were given different combinations of vaccines throughout the season, we had 484 unique patients and 530 total enrollments. Of those, 39% were flu, 21% PCV13 or Prevnar, and 40% received the two together. There was a difference, not surprisingly, in the age group of the children getting the vaccine. For pediatricians in the audience, this is not unexpected. Children who received PCV13 alone were slightly more older. Overall, basically pretty much the same male-female, primarily Latino and Medicaid population, which is the community that we serve, and most children were not at high risk for flu. In terms of the caregivers, they were mostly 6 to 29 years old, English, Spanish speaking, had at least a high school education, though many just had a high school education, had unlimited text messaging, and most texted frequently. In terms of response rate, this is first looking overall, so this doesn't account for whether a message was actually delivered or received. Response rates on day 0 were about 72%. If we look at the overall response rate, so in terms of these are where we know the message actually got to the patient, then day 0 response rates were 95%, and that was down to about 80% on day 7. And there were no demographic characteristics that affected likeliness to respond other than caregiver age. So parents who were slightly older were more likely to respond. There was no difference based on text messaging plan, but there was a difference based on pre-enrollment receipt of text messaging. So those people who never received text messages before, even though they signed up, they didn't really respond, which is not surprising. But I think the important thing is those who only text on a monthly basis were very likely to respond, with 6.7% on day 0 to 1, 56% on day 7, and then not surprisingly, those who texted frequently are most likely to respond. In terms of fever rates, we did see an increased fever rate on day 0 to 1, with 37.6% of those who received the vaccine together having a fever compared to 7.6% who received TIV alone. That was a relative risk of 5 and an adjusted relative risk of 3.14. And we adjusted both for age because it was different between the groups, and then also for common and activated vaccines that are given at the same time, which could also cause a fever in day 0 to 1. And at a temperature of 102.2, we saw the same with an adjusted relative risk of almost 5. Comparing the simultaneous vaccination against PCV13, we had similar findings at the level of 100.4 with an adjusted relative risk of 2.8, but we did not see a significant difference at 102.2. And we did not see any difference between groups on days 2 through 7. We conducted a survey with 325 parents who enrolled in the study, and 94% said they would be willing to re-enroll. And nearly 2/3 preferred text message reporting to paper reporting, and an additional 20% had no preference. So there are limitations to the study. The first is process issues, so we had issues with our text message delivery. Also, these are patients from one practice network, which primarily Medicaid patients, and they had very high rates of cell phone and text message usage. We didn't randomize families, and so these vaccines were given along with other vaccines. And for those in the vaccine world, we couldn't look at DTaP alone, which is something you might want to look at in that day 0 to 1 period by itself, because it was primarily given along as Pentosil, which is a common combination vaccine. But in conclusion, we did see higher fever rates with the concomitant dosage of PCV13 and TIV compared to TIV alone and compared to PCV alone in that day 0 to 1 period. And interestingly, some odd months ago, there was a paper that reported doing a similar study in Canada using paper reporting, and they also saw an increased fever risk with PCV13 and TIV together versus TIV. So that actually lends somewhat of validity to using text messaging for reporting, because we were able to see the same thing using text messaging as they could see in paper reporting. And so we felt text messaging was successful to test a vaccine safety hypothesis during an influenza season. Nearly everyone had text messaging. Most people had limited plans, and so cost really has not at all borne out to be an issue in any of our studies. There were very, very high rates of enrollment, even in a low-income urban community. And people reported through 7 days, and only caregiver age affected reporting, and so really we feel like a lot of people would use this system. And those who only texted monthly still reported, so you don't need to only rely on people who use text messaging frequently. And then there were high satisfaction levels. And so overall, we think that text messaging does have potential to complement these other available ways of assessing for vaccine safety. And I just want to thank our team at Columbia University and the CDC. I guess we have time for a couple questions. I think they want to use the microphone, right?
Hello. Okay. 2 quick questions.
Sure.
One, were you able to validate these findings in some subset of the subjects? The other is, are you a little nervous about sending PHI on SMS channels?
Sure. We did actually, in the middle of it, use paper reporting as well, just to get a sense of whether they're willing to do that. We haven't yet compared the text messaging versus paper reporting. But one thing we did notice that it took, on average, about 19 days from the start of the study to even get anything back in a self-addressed envelope, which may be fine if you don't need to act quickly. But if it were some kind of public health surveillance or study where you needed to right away be able to get to those families, I think you really need to use this rapid. And I think the PHI part is complicated. This is a research study, and so the text messaging companies signed all the agreements that had to be signed between us, and we went through IRB and all of that. And it was information that the families were sending to us. We weren't really sending information to them. It was more of a query. So I think that, but I think if this ends up being used in a more medical arena, that's something I think that we should talk about.
This question is more related to the study than to the technology related to the study, but I was wondering if you had follow-up data on these children, and if you found that the high fevers and the seizures continued for those that had the vaccines in combination as opposed to those that had them individually.
Yeah, these are very short-lived. In terms of fever, we didn't conduct surveillance for febrile seizure in this study because we obviously our group was too small to do that. But the fevers really were just in the day 0 to 1 period. So when you go out through day 2 through 7, there really wasn't an increased risk of fevers. These were short-lived fevers, and I didn't have time to show you that the medical visit. Nearly none of these actually resulted in visits, which is good, and maybe I think 7 or 8 of all of them.
Hi, my name is Fahad Pervez. I am a PhD student in Computer Science Department of University of Washington. Today I'm going to talk about Punjab IDS's visual work I started in 2011 when I was an RA in Lahore University of Management Sciences. We started this work with researchers from New York University and in collaboration with Punjab ID Board, which is a government department. This whole thing started in 2011 when Pakistan faced their first large spread dengue outbreak. Dengue is a mosquito vector-borne disease. Common symptoms include fever, fatigue, vomiting, among many others. It's similar to malaria in a way that it spreads through mosquitoes, but it's much severe. That is mainly because there is no medication for dengue. All you can do is maintain proper fluids. In 2011, when this happened, most of the people in Pakistan didn't know about dengue. As you can see on this map of Pakistan, it shows a spread of dengue disease. Most of this area got highly affected, which is Punjab province of Pakistan, and you see the intensity in this area is really high, which is Lahore city. Lahore is the second largest city of Pakistan and is the capital of Punjab province. Over 300,000 people got affected, 21,000 confirmed patients were reported, and unfortunately 300 people died. As a response to this outbreak, Punjab government started implementing several real-time surveillance systems, which include 3 different systems. We're going to talk about them in detail later. While we work with them in coming up with recommendations how to make these systems effective, we also work on more intellectual systems, which were based on the data coming from these systems to give government more insights of how the disease spread is happening. So the first system is patient reporting system, which is an online web-based tool where hospitals can log in and report the patient data. Only 10 hospitals were reporting the data in Lahore. All of them were medical teaching hospitals, and that's the reason why government was able to force them to report their data. The benefit of this system was that not only government was getting patient count daily as opposed to weekly or monthly, but they were getting the exact addresses of those patients, so they knew what is the current situation of dengue area-wise. At the same time, they implemented another system, which is a health hotline. It's a kind of calling service where people can call and talk about various problems. They can talk about that they have these symptoms, so do they have dengue or not, and what should they do next. Or they can complain about various problems in the community, like debris, ponds of stagnant water, or loss of mosquitoes, which are the vectors of dengue. So government can send their field teams to clear those out. So here you can see that these are the calls, location of these calls. With green means that the calls were resolved because those calls were complaints. The blue ones are the ones which are unresolved, and the yellow ones were not complaints. This graph shows the number of calls which were received during 2011 outbreak, and the total number of calls were around 100,000 with the peak of 4,800 calls per day. Due to the popularity of this system, we started looking into the data of this system, and we were looking for some trends which might show us that we can predict and we can use this as an early indicator. So we took both the data sets from health hotline and patient reporting system. We smoothed them and aligned their peaks, and we saw that these graphs, the red line shows the data from hospitals, and the blue line shows the data from health hotlines. And this graph is from Lahore city, and these 3 graphs are of 3 towns within Lahore city. You can see that both of the data sets are following the same trend, which shows us that we can use this to predict what's going to happen next. So we analyzed this data and trained our models, and here we have 3 different graphs of 3 different towns. So what we were doing is we were taking patient data and health hotline data, and we were predicting the number of patients that are going to appear in hospitals. The prediction was really good. And we were able to predict the number of patients 11 days early. You can see that there's an 11-day gap, which was a good result. So we started looking deeper into this data. So we wanted to go at a sub-town level. Our model's result was not that great, but was good enough that we can raise an alert based on that. And so we gave a government a system in which they can see in the whole city of Lahore, there are these red dots which are representing sub-towns. Red means that there is an outbreak alert, and green means that there is no outbreak alert. So all of this happened in the middle of 2011 outbreak, so we can't exactly show how the whole thing spread in 2011, but we can show how it's tapered off. So we are going from, this was the situation in December 1, 2011. As we step week by week, you will see that in a certain part of the city, there are green, these dots are becoming green, which shows that how the outbreak is tapering off. So this system was used by the government to track where's the current disease spread and perform their preventive activities, which is all good. So in Lahore, we were seeing data at a very fine-grained level, but we didn't have any idea what's happening in other cities of Punjab. And that's because hospitals were not reporting any data from those cities, or the data was being reported after a month, which was too late. So we started looking at alternate sources. We know that there are news reporters report all kinds of important, non-important stuff, and this is obviously important. So we took data of all the English newspaper in Pakistan, 5-year data, analyzed it with the dengue records, and we were able to train our models to tell us what's happening in the other cities. So this is the graph which you can see from, and it's based on the patient data coming from hospital. And this is the map you can see, which was basically from a system based on the newspaper data. So you'll see that this is telling that there's an outbreak in Lahore, and this system is also telling that there's an outbreak in Lahore. And both the systems tell the same thing throughout the whole 2011 outbreak. So they are consistent about Lahore. But this data has no information, this system has no information about other cities, but we were able to tell what's happening in the other cities of Punjab and even in some other parts of Pakistan. And here we're showing a case study of Multan, where we show on a temporal line that how from August 11 there was no outbreak to in October there was a high outbreak alert to November 23 when the outbreak tapered off. So we cannot use this for outbreak detection, but we can use this to tell us something about what's happening in those cities where there is no data being reported. So all of this data, government is seeing all of this data. So what's their response to this data? So what they did was that they sent out these field workers to perform various kind of preventive activities. But since we're talking about developing countries, the government employees don't work that hard. So government want to make sure that they are performing those activities and government is getting a real-time data. So what they did is they gave an Android device to all the field workers with their application installed. So every field worker has to go to a place, take a picture of before performing an activity, and then perform that activity, and then take a picture after performing that activity. Every picture get automatically geotagged, so we know that that health worker was there and performing that activity. So government can see that on a web platform, and they can click on each activity and see who performed that and what was being performed. So now what we want to do is we have these questions that how effective these preventive activities were. So we started putting preventive activities with the actual patient data, and you see that government is performing most of so these blue-red clusters are the clusters of patients being reported from the hospitals. And these red dots are the activities being performed in all these areas. Most of these activities are performed where the patient is reported, because that's where the high severity is coming from a system. But we want to learn that what is the impact of each of these activities, and how rigorously these activities have to be performed, and implement a suggestion system for government. We are still working on it. We have lots to learn from it. So I would want to conclude by saying this, that there's one thing that government do a lot of data collection, but there's a completely different thing that government understand the data and act accordingly. We implemented systems so government can understand what the data presents. And that's the reason in 2012, Punjab government was able to contain dengue outbreak with just 234 patients and 0 deaths, which was a big success for us. I'm open to questions.
Hi, I'm Jamie Skipper from, I guess you can hear me, from the ONC. I was interested in what information from the hospital is being sent over to you to indicate that this outbreak is occurring?
So hospitals just sending the patient data, that this patient with this name, with this address has appeared, and whether he's a suspected patient or a confirmed patient. But the government sees there's the first system which we built for government was this system, which is giving them a picture based on that these are the areas which are getting outbreak alerts. It's a warning and outbreak alert, but based on the data coming directly from the hospital. So so hospitals are not telling the government that is there an outbreak or not. It's the epidemiology department tells them, and this data is this system was built on the feedback of epidemiology department.
Oh, okay. Great. Thank you.
Good afternoon. I'm Sonia Gonzalez. Thank you all for your talks. My question is for you, but I'm interested in anybody's response to this. I was recently on the ground helping with Hurricane Sandy relief, and it just seems to me that there's so much potential for many of your apps, many of your texting devices and technology to be applied in emergency relief kind of situations. Can you respond to how you might be open to sharing this sort of technology and getting it out there for that kind of work in particular?
Right. In my opinion, that most of the work being done for developing region can automatically be applied to developed countries when they are in disaster, because when they are in disaster, they are pretty much like acting like a developing country with limited resources and everything. And all of these technologies can easily be adapted to developed countries, and I think that we might have less challenges, because with these systems we have a challenge of literacy and all and those kind of things. But in implementing something like this in America, it's really easy, because people would still people have this sense of responsibility and education. So I think that this system would be very successful in disaster situations. Right. Maybe I'm not that familiar with the rural areas here, but... Oh.
I'm happy to share data if you want to discuss it later. But
yeah, I think that they might have some suggestions too.
Yeah, I think this is a topic that's been thought about a lot. There's a crisis mapping that's looked a lot into this. Developed the Ushahidi software, which is an application that deals directly like described, there's a bias with stuff like that. Because if you're receiving a text message, or if someone's reporting on an app, it means they have a phone, they have the money for mobile service, and that the mobile service is available. I think what was seen in some places in hurricane affected by Hurricane Sandy is that the mobile towers were down.
So Wi-Fi in many cases was up.
Yeah.
I mean, it was a very mixed bag of situations.
Right.
It wasn't a singular, again, it wasn't a singular situation.
Right.
I'm just trying to think ahead here, you know, I'm just,
No,
that's why I'm asking.
it's like an interesting outlet to try and consider, but the idea of maybe not as a singular solution, just because that data you're getting is going to be incomplete from some areas where the resources are just not the same.
Speaking more as a New Yorker than the kind of work that I do is more education messages and text messaging. I think where it would have been particularly useful. I'll speak loudly. I think where it would have been useful in Hurricane Sandy may have been to connect volunteers with needs, because I think that's a lot of what happened was that people were ready to come and volunteer and they didn't know where to go. And so if I were pie in the sky, it would be to have some kind of app or something that could have said, well, we need people here, and this is who you talk to, and this, and I think part of it was that there wasn't a lot of, there was not as much coordination going on as that probably could have gone on. But I think you're right, you know, that there were cell phone towers were down in Lower Manhattan, although I think Wi-Fi was working, and I think, but in general, I think cell phones are a very good way to reach people, and certainly where I work is a very low income, minority population, everybody has cell phones. They don't necessarily have smartphones, but everybody has cell phones. And so I think that actually is a really great way to reach people, and we don't use landlines anymore. Most people don't even have landlines. Mailing addresses, people are moving all over the place, but we've really found cell phones to be a pretty stable way to reach people.
We actually have time for more questions for any of the panelists.
Hi, I'm Marissa. I'm from Health Alliance International, and I had a question for Fahad. How did you get people to call a hotline? Was it a number that was free? Was it very easy to call in? Because I think in certain situations, getting the information out and known to people that they can call in seems a bit of a challenge.
Yeah, so this was a toll-free number which government implemented, so there was certainly no cost. And we're talking about Pakistan, where there is this cell phone network is good, especially within cities. People have cell phones, but they're not ready to spend any money, so they can call to a toll-free number. Okay, and how did government make the publicity? So what they did was they posted a lot of banners, and they posted on radio and television, because it was chaotic at that point, because people didn't know what this disease is. That was the more scary thing about this, that a lot of people in hospitals didn't know what's happening, didn't know how to avoid it. And I'm not just talking about poor people, I'm talking about normal people too, rich people too. People didn't know how it happened. And I was there during that time, and a lot of my colleague researchers got affected with dengue. But that was a situation which the whole country faced. So I think, and at some level, once this word starts to spread, virally, a lot of people learn about this service.
Okay, if there are no other questions, please join me in thanking our speakers.